First is looking at the definition of depression and what is depression. Many of us sometimes often think that depression has to do with just the psyche. However, depression can be a whole body illness. It can last for a few days or it could last for many years. When a patient experiences major depressive episode, they can experience a number of symptoms. One of the things they experience is anhedonia. And what is anhedonia? Anhedonia is really the loss of pleasure or the loss of ability to experience pleasure. So giving an example of that is if you once enjoyed movies, hanging out with friends, when you're going through that episode or depressive episode, those activities may no longer appeal to you. You might tend to isolate yourself away from friends. Other symptoms are vegetative symptoms. And what are vegetative symptoms? These are changes in physiological functioning. When we say changes in physiological functioning, could be things like simply not being able to change an appetite or bowel patterns. So just how the body physiologically function with your depression, it has an effect. And hence going back to it's more than just affecting the psyche, it's a whole body illness. Patient experience changes in appetite. They can experience insomnia, and insomnia is pretty much a lack of sleep or unable to fall asleep. Or they can experience hypersomnia, where hypersomnia is you're sleeping too much within a day's period. So you can go from one end of the spectrum to the other, where sleeping too little, or hypersomnia, where you're sleeping too much. Patient may experience anergia or anergy, which is a fatigue or decrease in energy. So often they feel they have no energy, or they feel very fatigued over a course of time. And then because of the decrease of energy, they can experience psychomotor retardation, where the person's thinking and body movement and speech becomes noticeably slow. All right. They can also experience psychomotor agitation, which is really, you notice people, if they're experiencing symptoms of depression or anxiety, this constant pacing back and forth or constantly wringing of the hands, of displaying inability to cope with their stressors at that time. So not in so much of just I guess for knowledge purposes, there's several levels of depression. One of the very first levels of depression is mild depression. So it's very short-lived. Usually it's triggered by life events. And it's only where a patient might be complaining of feeling lost or feeling disappointed. Usually it occurs after suffering like an important loss. So let's say you're going through a divorce, or you just lost your job, could be you were laid off, and you're just at that time feeling that sense of disappointment. I'm feeling down, but again, very short-lived, and as often patients can cope, they can eventually get to using their resources and be able to deal with that episode of mild depression. Then we have moderate depression, where there's a little bit of a higher risk for suicide at this point, persists mostly over time, and it could start to, the feelings of being depressed starts to interfere with the patient's activities of daily living, because again, like we mentioned from the previous slide, they're starting to experience that anergia or that lack of energy. It can also start to have more of a vegetative symptoms, so physiological changes, where women can see changes in their menses. It can affect sexual functioning, inability to start to enjoy pleasures in life, so that word anhedonia again. So now we're looking more at that increased risk of that patient having a suicidal plan, suicidal ideations, and how they're going to go through with that plan. And that is usually, as a nurse working in psychiatry, that's probably one of the key things is with patients experiencing depression is during your assessment, noting if that patient has a risk for suicide. And it's more than just asking, are you planning to commit suicide? It's also noting, is there a specific plan? Is that just a suicidal ideation? And if they have a plan, what does that plan sort of look like? The third is the major depressive episode. And with major depressive episode, this is where the patient starts to experience their symptoms for a minimum of a period of 2 weeks in order to be diagnosed with major depressive episode. They don't always, you have to be conscientious that patients do not always describe their mood as being depressed during these phases, but is looking at the patient as a whole. So are there other symptoms this patient is experiencing? Are they showing a marked decrease of interest and pleasure and activities? Is it affecting their ADLs? Are they having poor appetite? Do they seem to isolate themselves? So even though a patient may not say, I am feeling depressed, it's also looking at the surrounding signs and symptoms or other behaviors that's being displayed by this person that is highly indicative of a major depressive episode or major depressive disorder. So the major or the primary classes of antidepressants that we'll be looking at are tricyclic antidepressants or TCAs, your SSRIs or selective serotonin reuptake inhibitors, your MAO inhibitors are monoamine oxidase, and there are probably very little mention of your atypical. So the three major class. When you're reviewing these medications, please ensure that you look at the mechanism of action of the medication, the therapeutic effect or the therapeutic outcome of those medications used in the treatment of depression, side effects or any major drug-drug interaction or drug-food interaction when patients are taking these medications. So the very first class. So the first classification of antidepressants that we'll be looking at is TCAs or tricyclic antidepressants. Just to note, this is probably not an antidepressant that you will see quite commonly because of the adverse effects. The compliance is not that great with TCAs, so it's not commonly used. These drugs are mostly reserved for patients with major depressive episode or major depressive disorder. So the prototype drug for TCA that we'll be looking at is a drug called tofranil. How does the drug work? It inhibits the reuptake of norepinephrine, serotonin, which is 5-HT, or dopamine, which is D2, into the presynaptic nerve terminal. So if you remember from the previous recording, once neurotransmitters are released into a synaptic cleft, if it is an excitatory neurotransmitter, that action potential will move from your pre to your postsynaptic, and once that has been achieved, we would like to terminate the action of the neurotransmitter. There's two ways of terminating actions of neurotransmitter when they're in a synaptic cleft, and that's by enzymatic breakdown of that neurotransmitter. So for example, if you think of acetylcholine, if you can remember from anatomy, is broken down once it's used by acetylcholinesterase. So that's just an example. Or we can get rid of them by reuptake into the presynaptic terminal. Well, these drugs work by preventing that reuptake from happening. Why does it do that? Because it wants neurotransmitters such as norepinephrine, 5-HT, and dopamine to stay longer in the synaptic cleft. Because also from the previous recording, it was noted that these neurotransmitters have a significant role in improving mood, emotions, and therefore alleviating signs and symptoms of depression or sadness or hopelessness. So therefore, we want to keep those neurotransmitters longer in the synaptic cleft to prolong their effect or prolong their ability to allow for neurotransmission. Unfortunately, TCAs also block other receptors such as muscarinic, histaminergic, adrenergic, and dopaminergic. And these is what bring about the side effects that is seen with these medications, often that affects compliance with the drug. So just to recap, the first bullet point, where it inhibits the reuptake of neurotransmitters such as serotonin, these guys bring about the therapeutic effect of the drug. So this is what we want to occur in the patient. So it brings about the therapeutic effect or the therapeutic outcome in your patient. However, if you remember from Patho 1 pharmacology, we cannot always with medication be selective in the receptors that we're blocking. So unfortunately, by blocking these other receptors, side effects have been created with these drugs. The therapeutic effects or the therapeutic outcome is therefore increasing these neurotransmitters in the synaptic cleft, allowing for more neurotransmission, to be brought about, alleviating symptoms of depression. So continuing on with TCAs, we're now going to look at the key side effects and why they occur when tofranil attaches to these different receptors. So let's look at the first one, for example. Adrenergic receptors, when they're blocked, would result in orthostatic hypotension or antihypertensive effects. Now, why is this occurring? So if you remember, alpha-1 adrenergic receptors belong to the SNS system. So therefore, when epinephrine or catecholamines attach to alpha-1 adrenergic receptors, it causes vasoconstriction to occur. And once vasoconstriction occurs, that results in an increase in blood pressure. Now we're saying tofranil attaches to or it blocks these receptors, and it blocks epi from attaching to adrenergic, so everything gets reversed. So now your patient would experience vasodilation. Once they vasodilate, their blood pressure is going to drop because now things like their stroke volume, their cardiac output, all that stuff is dropped, resulting in a decrease in blood pressure. Therefore, the patient is going to start to experience orthostatic hypotension. When we look at the dopaminergic receptors, we talked about the basal ganglia, and we talked about basal ganglia having dopamine, again from Patho 1, and in there, it plays a role against acetylcholine. Acetylcholine is excitatory, dopamine is inhibitory, and that basal ganglia or substantia nigra control the extrapyramidal pathway. And what does the extrapyramidal tract controls again? Involuntary movement, right? So it controls all the involuntary movement that can be seen in a patient. So by blocking dopamine, you now allow acetylcholine, which is excitatory, to be able to take over. And so you're going to start to see increase in involuntary movements in the patient. So almost like Parkinson's symptoms. So when you start to look up, or once we talk about antipsychotics and we talk about extrapyramidal effects, all the different types, i.e. things like tardive dyskinesia, dystonia, those are the ones that really, it can also manifest with the use of TCAs. In terms of histamine receptors, when histamine attaches to H1 and H2 receptors, they bring about certain effects. But just think of using something like Benadryl. What happens? Sedation occurs, right? So histamine attaching to these receptors result in sedation in the patient or makes you feel sleepy. Muscarinic, or cholinergic receptors belong to the parasympathetic nervous system. So these guys belong to your PNS or your parasympathetic nervous system. In other words, rest and digest. So when you think of your rest and digest, what are some key things occurs with rest and digest? So you increase salivation, increase in urinary output, increase in peristalsis. So you're digesting, right? You're resting and you're digesting. Increase in mucous membranes. A decrease in your heart rate and blood pressure. So when you reverse this, now it's the same thing. To these receptors, or these cholinergic receptors, if you can recall from anatomy, cholinergic receptors usually binds to acetylcholine. These drugs are now going to block cholinergic receptors from attaching to acetylcholine. And when it does that, all of your symptoms or your effects that you get will now be reversed. So decrease in salivation, so your patient has dry mouth, decrease in urinary output, so they're at risk for urinary retention, decrease in peristalsis, so they're at risk for constipation, increase in their heart rate, so they're at risk for tachycardia. So this is sort of gives you an idea. So just sort of think about it once a patient is experiencing all these key side effects, what the compliance would look like with taking a drug like TCA. So the second classification of drugs that was used to treat depression was your SSRIs. These drugs are more common in their use to treat clinical depression. So these are things many of you might be more familiar with, these drugs, things like Prozac, Celexa, Paxil, Zoloft. So what is the mechanism of action of these drugs? They inhibit serotonin, and the reason it's selective serotonin, so it only inhibits the reuptake of serotonin into the presynaptic nerve terminal, and therefore more serotonin will now be available in the synaptic cleft. Serotonin was our happy molecule, so it means that the more serotonin that's left in the synaptic cleft, the more neurotransmission is allowed, and therefore it allows for improve in mood and neurotransmission. What is great about SSRIs compared to your TCAs is they do not have the same amount of sympathomimic and anticholinergic effects. So therefore compliance is a little bit better. Also sedation is less frequent, whereas in TCAs, because they block histamine receptors, you see a lot of sedation more with the TCAs compared to the SSRIs. So SSRIs are more frequently used antidepressants that is used to treat clinical depression in a setting. Continuing with our SSRIs, looking at key side effects are things like sexual dysfunction is often the most common side effect seen with the use of SSRIs, weight gain, insomnia. From past experiences, patients would often say, I feel like someone has poured like cold water on me, with the insomnia they experience sometimes, or they feel like they have this gush of energy, and it's almost like they try to unwind, but they can't unwind because they feel like the medication keeps them going. This feeling of nervousness. The great thing, however, about it does not block cholinergic receptors, so it doesn't have any form of anticholinergic side effects that you would see with this particular drug. One other key thing to always be conscious of, and clinically I've only seen it in a few case scenarios, are something called the serotonin syndrome. And with serotonin syndrome, or your SES, this is where the patient has too much serotonin on board. So now they have sort of an excess of serotonin. So this is called the serotonin syndrome, or SES. So patient has excess serotonin. And when could this possibly occur? So it could occur when you take an SSRI. Remember, SSRIs are blocking the reuptake of serotonin. So now I have excess serotonin in the synaptic cleft. And if the physician was to prescribe an SSRI along with a TCA, remember, TCA also blocks the reuptake of serotonin. So now your patient pretty much have an excess of circulating serotonin in their system. So they start to experience symptoms that they're in a hypermetabolic state. So you can start to see changes in their mental status. They tend to present with high blood pressure, hypertension, diaphoresis or sweating, hyperpyrexia or high temperature. They can appear confused and ataxic. So ataxia is an alteration in their gait. Also, this can also occur. I know I mentioned TCAs because we've already covered TCA, but once we cover MAO inhibitors, you'll also note that combined use of an SSRI with an MAO inhibitor can also result in serotonin syndrome. So it's my belief that before we look at monoamine oxidase inhibitors, that we first take a look at what is the role of the enzyme. So the role of the monoamine enzyme involves the inactivation of neurotransmitters, and pretty much the key neurotransmitters that you've been seeing repeatedly, serotonin, dopamine, and norepinephrine, has now been broken down or endure the enzymatic breakdown by monoamine enzyme in the synaptic cleft. So remember again, when we want to get rid of a neurotransmitter, from the synaptic cleft, we can either have it undergo enzymatic breakdown or reuptake. So far with your TCA and your SSRI, that had to do with blocking the reuptake. Now we're saying monoamines has to do with breaking down. So it's involved in the enzymatic breakdown of these neurotransmitter. So once you're finished, this monoamine enzyme breaks down these neurotransmitter and get rid of them. Okay. One more thing about monoamine enzyme, they help to degrade the amino acid tyramine in the intestine. So there is an amino acid called tyramine, where in in other form of an amine group, it's tyrosine, but it's an amino acid. Once you consume foods rich of tyramine, monoamine enzyme also break down this tyramine in the intestines. So monoamine oxidase inhibitors are the third classification of antidepressant. The mechanism of action of these drugs are they inhibit the breakdown or the enzymatic breakdown of norepinephrine, dopamine, and serotonin in the CNS neurons by inhibiting or blocking the action of the monoamine oxidase enzyme. Usually, once you do that, like we said, these neurotransmitters are important in mood, so higher levels will be trapped in the synaptic cleft, intensifying neurotransmission, improving mood and emotions, and alleviating depression or symptoms of depression. Almost like your TCAs, these drugs are not often used to treat clinical depression because they tend to have a lot of drug and drug or drug and food interaction. So they're only now used for patients that do not respond to other forms of antidepressants, such as things like your SSRIs. So monoamine oxidase inhibitors have key side effects. So things like orthostatic hypotension can occur, headache, insomnia, diarrhea. But the key is they tend to interact with a large number of foods and other medications causing side effects. One of the common food groups that it interacts with is patients experience symptoms when they ingest foods that are rich in tyramine, which is an amino acid. They tend to experience hypertensive crisis. If they are on MAO inhibitors and they consume foods rich in tyramine. What types of foods are rich in tyramine? Usually it's foods that are fermented, cured, aged, or spoiled. So processed food, cheese, things like wines, processed meat, those are the kinds of foods that are often rich in tyramine. So now looking at why does hypertensive crisis occurs in patients that are on monoamine oxidase inhibitors and they consume tyramine-rich foods, such as wine, cheese, processed or cured meat. Tyramine is a form of amino acid, and then it can also be used as tyrosine based on a removal of an amine group. from previous slides, we talked about one of the actions of the monoamine oxidase enzyme is to break down the amino acid tyramine in the GI tract once it's consumed. Now, if you think about it, if a patient is on an monoamine oxidase inhibitor, they no longer will be able to break down tyramine. So once you've consumed tyramine-rich foods, you have excess amount of circulating tyramine. Now, tyramine has the ability to displace neurotransmitters such as norepinephrine or dopamine from the synaptic cleft. Okay, so it's able to displace those neurotransmitters. So now you're going to have increased amount of norepinephrine that is being released. These norepinephrine will now attach to adrenergic receptors. Okay, once they attach to adrenergic receptors, just think back to yourself again. What are adrenergic receptors? Adrenergic receptors are in the SNS, right? The sympathetic nervous system. So adrenergic receptor binds to epinephrine. And when they bind to epi, just think it back again to your alpha-1 adrenergic. What happens? Vasoconstriction happens, and we now have increase in resistance and increase in blood pressure. So because of the sudden release of the norepinephrine, your patient goes into acute hypertension or hypertension crisis, pardon me. So this was often called back then the wine and cheese effect. Some textbooks will call it the cheese effect, because this is how they realized, or this is how it was diagnosed. Patients that were on monoamine oxidase inhibitors will go out to socialize or at a party, and once they consume wine or cheese, they would have the worsening headache of their life, which was as a result of the increase in the blood pressure.